Yeah, so HER2 amplification was assessed on the study based mostly on immunohistochemistry. This was done because it's pretty accurate. It does a pretty good job of assessing for HER2 amplification, and also it's feasible. So you can do it on tissue pretty quickly as opposed to extended sequencing, which typically can take a couple of weeks. Patients that had HER2 amplification, as defined by immunohistochemistry score of 3 or more, were allowed on the study, or if the patients had 2+ staining on immunohistochemistry plus an amplified FISH study, they were allowed on the study. We also did next generation sequencing on all folks, and we assessed patients for KRAS mutations. I didn't mention this, but patients that had KRAS mutations were not allowed on study. We actually didn't find any patients in our screening that had a RAS mutation as well as the HER2 amplification, which is pretty interesting. We screened over 500 people. So in the stage 4 setting, you see RAS mutations in, between 20 and 40% of people with HER2 amplification. So that in itself was an interesting finding that maybe RAS mutations happen after HER2 amplification, or maybe in the early stage setting, they're not as relevant. But to go back to your question, the HER2 has been studied in a number of different cancers. The things you have to keep in mind are there can be heterogeneity in the tumor. So we didn't find that in our study because we only have one tumor site that we biopsied. But and most of the patients had 3+ or more staining. But that can be a phenomenon that is witnessed in other cancers such as esophagogastric cancer, and theoretically could be seen in rectal cancer too. If we see more patients, maybe we would find that. We also did next generation sequencing to evaluate for DNA amplification. So not doing the protein staining, but looking for DNA. Interestingly, we had we had a couple patients on the study that had immunohistochemistry positive, but their DNA sequencing was what we call normal, which was very interesting. And that wasn't an inclusion criteria for the study, but we think, and it's one of the messages of the trial, that maybe the DNA amplification is actually more important. And to prove this point, we looked at patients that had a complete clinical response, and we compared those 4 patients to the 4 patients that did not have a complete clinical response with only the chemotherapy and HER2 treatments alone. And what we found is the biggest predictor of the clinical complete response was actually the genomic amplification of the DNA, which is really interesting. All of the patients with a complete clinical response had high amplification of their DNA. There was one patient which is still pending. Um, uh, on patients who did not have a complete clinical response, those patients had significantly less DNA amplification as done by next generation sequencing. Interestingly, too, all the patients with a complete clinical response also had HER2 3+ amplification. The folks that did not have a clinical complete response, many of those patients had 2+ amplification on the protein staining. They had a positive FISH, so they were eligible for the study, but their level of amplification was lower. So hence the title of the talk, we think that the genomic amplification of HER2 is very important in this setting.